Bismillah ar-Rahman ar-Rahim. Upper GIT bleeding. Will be our second lecture in this series. We talked previous lecture about acute appendicitis, and we are going to talk this time about upper GIT bleeding. This important subject is very important in the treatment because it is life-saving, number one. Number two, it is endangering the life of so many patients. So diagnosis and treatment, acute treatment of upper GIT bleeding is an important thing. In this lecture, we are going to tackle the anatomy of the gastrointestinal tract, and we are going to give the definition of this upper GIT bleeding, the pathophysiology, and we are going to mention just the causes, and I believe some of few are going to read in depth about the causes of this upper GIT bleeding. The important thing is the clinical approach to this condition, which entails taking good history, doing a physical examination, doing some investigation, and how to treat this condition in acute phase when there is excessive bleeding and endangering the life of the patient, or when there is chronic bleeding and chronic anemia and the other complication of upper GIT bleeding. Upper GIT bleeding is divided into two. GIT bleeding in general is divided into two types: upper GIT bleeding, which is going to be discussed in this lecture, and lower GIT bleeding, which is going to be discussed in another lecture. On the anatomy of this GIT tract, the GIT tract is divided into upper and lower GIT tract by the ligament of Treats. Treats is a known Czech pathologist who lived in the 17th century, and he describes this ligament, which is joining the duodenojejunal flexure to the right crus of the diaphragm. It's a fibromuscular band which is joining the 2 points, and it is important in the diagnosis of upper GIT bleed, because any bleeding below that is lower GIT bleeding. Any bleeding above this junction is upper GIT bleeding, and it is important also in children where the rotation of the intestine is going to occur around that ligament. The important part of this lecture is going to be the clinical approach of upper GIT bleeding, which is divided into the history, examination, investigation, and treatment. As I have said, the upper GIT bleeding is defined as bleeding above the ligament, what we call ligament of Treats. This ligament lies at the junction of the fourth part of the duodenum and the jejunum, and it is clear in this diagram, if you can see the diagram. The other diagram is showing the ligament of Treats with the duodenum in place, and the superior mesenteric artery and the celiac trunk with the posterior wall muscles and the diaphragmatic muscles. The pathophysiology of this condition is also known, this upper GIT bleeding is known as upper GIT hemorrhage. Could be a fresh bleeding, and the fresh bleeding is frank red bleeding, which could be excessive, and this will be a cause of so many problems. Or it could be an altered blood. The altered blood is a coffee ground type of vomiting, which is mixed with stomach content. Or patient can pass of upper GIT bleeding, can pass fresh blood through the anus, or he can pass blood mixed with the stool, what is called as hematochezia, or he can pass black stool, which is called melena. Frank red blood or coffee ground or to frank black, which is known as melena, may present as upper GIT hemorrhage. These changes are either due to a change by the acid in the stomach or by digestion of the blood in the gastrointestinal tract due to digestion. There is another important type of bleeding which is also have to be tackled and have to be diagnosed. This type of bleeding is called occult bleeding. Occult bleeding can be discovered accidentally or incidentally when the stool is examined for occult blood, what we call OFB test. Occult bleeding is bleeding which is not overt, and it can present with severe anemia and blood in the stool, and it might not present earlier. The causes of upper GIT bleeding are multiple causes. Some of them are very common, some of them are very rare, and one has to know them all. The most common cause of upper GIT bleeding are summarized in this table and is divided into two, what we call variceal bleeding and non-variceal bleeding. Variceal, varices is very common in our area because of the periportal fibrosis caused by the bilharziasis in the Jazeera area and in some other areas, and it is important because it is causes treacherous bleeding and it causes multiple problems like periportal fibrosis, and it will cause passing of blood in the stool, and then bilharziasis is causing a lot of other problems. Esophageal varices can occur also due to other causes than bilharziasis. It can occur due to severe liver cirrhosis, which is most probably due to alcohol or due to liver diseases. The lower esophageal varices can be a cause of severe treacherous bleeding. Occasionally, a significant vessels may be involved with consequent massive arterial hemorrhage, and which must be distinguished from variceal bleeding, which is venous. Other causes, which is common also, the peptic ulceration of the gastrointestinal tract, and this peptic ulceration is either gastric ulcer or duodenal ulcer or lower esophageal ulcer, and it comprises about 8 to 15% of it comprises 20 to 50%, not 8 to 15%, while gastroduodenal erosions, it entails a little bit lower percentage, 8 to 15%. Esophageal causes other than variceal, it comprises 5 to 15%. Mahler-Weiss syndrome, and this is a tear in the lower esophagus, which is both alcoholic and due to excessive vomiting, and it comprises 8 to 15%. Other causes, which are vascular malformation, which is rare, malignancies of the esophagus also can be a cause of bleeding. Malignancies and benign tumors of the stomach also can be a cause of upper GIT bleeding. Duodenal carcinoma also can be a cause. Other rarer causes like drugs, and this is why it is important in the history of upper GIT bleeding, you have to take good history of drugs. If the patient is using non-steroidal for joint disease, for back pain, for other conditions, which is using the non-steroidal anti-inflammatory drug. Aspirin also a blood thinning drug, and it can be a cause of bleeding because some of the chronic patients who are on aspirin daily, they can have severe excessive bleeding also. Steroids is a cause of weakening of the blood vessels, and it can cause bleeding also. Patient on anticoagulation like warfarin also is a cause of upper GIT bleeding. Causes in children a little bit differ from that of adults because children are not having this periportal fibrosis, liver cirrhosis, and alcoholic gastritis and so on, but they can have problem of the esophagus which are congenital, or they can have gastritis due to other causes, and also they can develop peptic ulcer diseases. This diagram is summarizing the etiology of the upper GIT bleeding, and you can see peptic ulcer disease is having the upper hand. Maybe 50% is due to peptic ulcer disease. Variceal disease also maybe 10%. But this percentage differ from one place to another. You can find Mahler-Weiss syndrome, esophagitis, and rarer causes, and you might not even find any diagnosis for the cause of bleeding. And this is what we call idiopathic bleeding of upper GIT. Up to 20% of upper GIT bleeding is idiopathic, and maybe due to other causes which are not undiagnosed, like hemophilia, pancreatitis, angiodysplasia, rectal portal hypertensive, which is not diagnosed, and gastropathy, which cannot be diagnosed earlier. This diagram will show you some of the cases which are the rarer causes: portal hypertensive gastropathy, aortoenteric fistula. Aortoenteric fistula could be a cause of treacherous bleeding and excessive bleeding. Although it is rare, like it have to be diagnosed early because it gives you arterial bleeding, fresh arterial bleeding, and very excessive. Angiodysplasia is a rarer cause. Osler-Weber-Trendeau syndrome also is a rarer cause. Meckel's diverticulum could be an important cause in children. One of the other causes, which is hiatal hernia, hiatus hernia is of two types, the sliding type and the rolling type. And hiatal hernia is a cause of so many symptoms, and it could present with upper GIT bleeding and vomiting. This diagram is showing how to deal with a suspected upper GIT bleeding. For example, in an emergency situation, you have to do your initial clinical assessment. Very quick. Initial clinical assessment entails pulse, vital signs, pulse, blood pressure, temperature, and general examination, and it entails initial resuscitation and stabilization. After the initial resuscitation and stabilization of the acute problem, you have to do the initial pre-endoscopic risk assessment or risk stratification, and to see if he is a low risk for rebleeding or is high risk for rebleeding. If he is high risk for rebleeding, this entails an ICU admission, an urgent or emergent endoscopy. And urgent or emergent endoscopy could be done in the ER or in the ICU or in the endoscopy room. If the patient is of low risk rebleeding, you can send him to the ward, or you can keep him in ER and do your endoscopy after the initial pre-endoscopic assessment and initial stabilization. After endoscopy, if you can clearly identify the cause as esophageal or gastric varices, you can intervene by your endoscope, and you can do band ligation, or you can do cauterization, or you can do injection of sclerosant. Even in an ulcer, if you find an spurt, you can coagulate it or you can cauterize it. Few causes like polyps, arteriovenous malformation, malarious tears, a difflurid lesion. If you find a mass or a polyp, you can deal with it endoscopically. If you cannot deal with it endoscopically, you can delay it for later on. Sometimes you might not find any source and the bleeding will stop, and this entails further investigation and management. The esophageal varices, as we said, endoscopic treatment, and you defer them for later proper treatment. Peptic ulcer, there is an intervention, immediate intervention, and then you can treat it medically later on. Other causes, as we said, bleeding disorders, which are rare causes, bleeding disorders like hemophilia, portal hypertensive gastropathy. This is because earlier on the portal hypertension, before making an esophageal varices, it can lead to hypertensive gastropathy. Aortoenteric fistula, as we have said, angiodysplasia, hemophilia, that means bleeding in the biliary tract, and it will go into the duodenum and it will present as upper GIT bleeding. Meikle diverticulum, we mentioned that is important in children, Best-Jaeger syndrome, and other rarer syndromes of the liver like Osler-Weber-Rendu syndromes. Important thing is the management of this upper GIT bleeding. As we have said, any management entails taking history, doing an oriented examination, doing investigations that is going to rule out or diagnose or give you the clue to the diagnosis, or the investigation for the general condition of the patient, and after that you start your treatment, and then you have to be careful about the complication and the prognosis of this condition. The history, you have to take good history if the patient is a smoker or non-smoker, because smoking is will make the bleeding excessive, and it is a risk factor for bleeding. Alcohol also is important in the bleeding because it causes gastritis and it causes vomiting, and it can cause malarial syndrome. And later on, alcohol for chronic alcoholism, they can develop liver cirrhosis and later on portal hypertension. So alcohol is important in the upper GIT bleeding. History of previous bleeding can be very important. The past history of that bleeding, is it treated surgically or medically, or it stops spontaneously, and what is the diagnosis of that condition, and is this condition is attached related to the previous condition or not. Drugs, history of drugs is important, non-steroidal anti-inflammatory drugs, because it is used in people who are older and having joint pain, back pain, and so on. Steroids also is known to be used for a long time in chronic diseases. Anticoagulant is used in some patients of heart failure and people who are having clotting factors, and aspirin also is used as thinner of the blood. Comorbidities are important in upper GIT bleeding because liver diseases, they are prone to vitamin K deficiency, diabetes mellitus, bleeding tendencies, peptic ulcer diseases, which are previously, they are prone to bleeding also, malarial syndrome, esophageal varices. History of this esophageal varices, even if it is due to portal hypertension or chronic liver disease and cirrhosis. History of trauma is also important. The color of the vomitus is important, and the amount also, you can tackle it from the history also. You have to examine the patient vital signs, pulse, blood pressure, respiratory rate, and skin signs, and you have to intervene directly by putting 2 wide bore needles and an immediate intervention. You have to give IV fluid, normal saline, 2 liters of normal saline if the bleeding is excessive and the circulation is jeopardized. GIT examination and general examination are important. You have to examine the patient generally, and then you have to examine the the abdominal examination. And your examination is not complete unless you do a perectal examination. A specific procedure for intervention and control of bleeding can be done during the initial assessment. What are the investigations for this condition? You have to do baseline investigation, as we have said, complete blood count and blood works like liver function test and coagulation profile, liver function test, renal function test, and ultrasound, CT scan, and MRI for the organs. And the most important thing is endoscopic diagnosis and investigation. Endoscopy allows visualization of the source of bleeding, and will allow you to demarcate the point of bleeding very clearly. Bleeding and therapeutic intervention or biopsy of the lesion is important because the endoscopy will enable you to do these things. Since in the majority of cases bleeding settles spontaneously, and this is very important in the upper GIT bleeding because most of the bleedings which are occurring, they can settle spontaneously following a pre-endoscopy assessment. If the patient is unstable, the best option is endoscopy under general anesthesia. And it should be done in the operating theater because it might need further intervention in surgical intervention. So treacherous bleeding can be taken to the theater where you can do the emergency endoscopy. There is a gastroscope and a duodenoscope or a laparoscope. There is an endoscope or a gastroscope. An appropriate multi-channel gastroscope should be available that allows for insertion of devices such as needles, probes, clips, applicators, whilst allowing irrigation of the condition and aspiration of the fluid. Endoscopic therapy should only be delivered to actively bleeding lesions. Non-bleeding visible vessels, and when technically possible to do the intervention during the bleeding. But if the bleeding is stopped, you have not to do any intervention. You have to defer it for later on. The endoscopic stigmata of recent hemorrhage can predict the risk of rebleeding and the need for endoscopic homeostasis or surgery. There are so many categorization of the bleeding and classification of the bleeding. How to do management in emergency situation or post emergency. As we have said, any emergency you have to start with the ABCs. You have to protect the airway, and you have, if there is anything that jeopardizing the airway, you have to interfere, open the airway. If you cannot open the airway mechanically, you can even open the airway by doing an endotracheal intubation. An IV line for fluids and cross blood grouping and cross matching is important. Monitor. You have to put the patient on monitor, and you have to put an indwelling catheter to monitor the urine output. You have to correct the clotting abnormalities. You have to monitor the pulse, blood pressure, and central venous pressure. You have to inform the surgeons of all severe bleeds which are endangering the life. This is most probably the main point in the high emergency upper GIT bleeding, and I think this is, you have to go to the paper which is given at the end of this lecture to see further management of the medical emergency of upper GIT bleeding. Post emergency treatment, I think it's easy. You have to locate the source of bleeding, and you have to diagnose the amount of bleeding which is occurring, and you have to stop that bleeding, example by endoscopic intervention or surgery, electrocautery, laser therapy, adrenaline injection, or banding or clipping. And you have to treat the chronic things which are occurring, the anemia and other deficiencies which are occurring due to the hemorrhage, upper GIT hemorrhage. This diagram is showing the Malarial bias syndrome, which is a tear in the lower esophagus or upper gastric part, and it is important to know this condition, and to know how to treat it and how to tackle it. What are the complications of upper GIT bleeding? One of the complications is shock, and this is, we talked about it. If you find the vital signs, for example, the patient is tachycardic, tachypneic, that he is entailed to jeopardize his circulation, and this entails the emergency treatment. Frank shock is an important problem, and you have to know how to manage frank shock by IV fluid and blood, and you have to guard against organ failures. Liver failure, because excessive bleeding can cause liver hepatic failure. Respiratory failure, if there is vomiting of blood and retching and aspiration pneumonia, can cause severe respiratory failure. Chronic bleeding for a long time can cause severe bleeding, and shock can cause renal failure, and these complications can occur in the upper GIT bleeding. The prognosis of upper GIT bleeding, as we have said, if it is not excessive, number one, it is part of the major bleeding can stop spontaneously. Some of them can lead to shock and lead to this severe bleeding can lead to shock and can lead to other complication, and it can lead to death. So managing the acute phase is very important to make a good prognosis. Melena can lead to chronic anemia, and chronic bleeding can lead to chronic anemia, and this is also, it could have other complications like heart failure, anemic heart failure, and other problems that will lead to infection and so on. I think there are two references you can go for it. Our Bailey and Love Short Practice of Surgery by the 28th edition, and the paper from the National Medical Library or National Institute of Health. You can go for it, and the site is there at the end of this lecture. We are going, if you have any questions, you can send it on WhatsApp, or you can send it on Instagram, or you can send it even by email, and we can discuss some of the problems if there is anything which is not clear. think one important point in the liver failure, one have to be clear that he can examine what are the signs and symptoms of liver failure before diagnosing anything else. For example, if there is jaundice, splenomegaly, or there is ascites, or there are skin stigmata of liver disease. Thank you very much. The other lecture will be next week. And there are some questions which are on acute appendicitis and our GIT bleeding. We are going to send it. Thank you very much.